Sir, you can start the session.
Yeah, okay. Just wait 1 more minute, it will start.
Okay.
Okay. Esmeda, I will start.
Yes.
Okay, so good evening to all of you. I will start with two short cases first, and then a long, interesting case. So, is my screen seen?
Yes, sir. Yes, sir.
Okay, okay. So, this is a story of a 44-year-old man. This case courtesy to Dr. Samia from Kolkata. This is a story of a 40-year-old fisherman who suffered from partial drowning 4 months back. He was initially given CPR, followed by ICU admission, wherein he suffered from 2 episodes of GTCS. He was discharged in a hemodynamically stable state, but was kept in tablet levetiracetam and Eptoin TDS from the local hospital. 15 days post-ambulation at home, he noticed difficulty in walking, with tendency to fall with no actual fall. He also reported flinging of the chappals while trying to walk with intact awareness and difficulty in negotiating both feet inside the chapel, but particularly with the left foot. He had significant difficulty in climbing upstairs due to gait imbalance. However, on climbing down the stairs, he noticed greater difficulty as his feet would not fall on desired stair step, often overshooting into the step lower down. He also had significant difficulty in sitting in the Indian side of latrine, as he would not be able to bend his knees fully, which resulted in worsening of the balance and tendency to fall backward. However, he has not sustained a single fall since the discharge from the district hospital. He also had difficulty in holding objects with his left hand, with the frequent falling of objects. He also had a difficulty in buttoning and unbuttoning the shirt, particularly with his left hand. So this is a story given by Dr. Samia. I will tell once again, it's no clear-cut history of any weakness anywhere, but is to have clumsiness of the hand with falling of objects from the hand. This is the main problem. After his cardiac arrest for a period of time, then he had noted difficulty in walking, tendency to fall with no actual fall. He also had flinging of the chappals while trying to walk with intact awareness and difficulty negotiating both feet inside the chapel, but particularly with the left foot. Significant difficulty in climbing upstairs due to gait imbalance. On climbing down, he noticed greater difficulty as his feet would not fall on desired stair step, often overshooting into the step lower down. He also had significant difficulty sitting in the Indian side of latrine, as he would not be able to bend his knees fully, which result in worsening of the balance and tendency to fall on backward. He had difficulty in holding objects with his left hand, with frequent falling of his objects. Also had difficulty in buttoning and unbuttoning the shirt, particularly with the left hand. He has not had any convulsions since his discharge, since the time of discharge. Now, this is the video of the patient. So there's no detailed examination. It's only the video is given to you or given to me, so you can see the video. He's going to stand on. See the exactly
আবার উঠে দাঁড়াও, এক পায়ের উপরে দাঁড়াও, কেউ খায় না, দাঁড়াও, দাঁড়িয়ে থাকো, অন্য পায়ের উপরে দাঁড়াও, তৈরি করি ওষুধ কি হয়েছে, উঠে দাঁড়াও। আচ্ছা আবার এই জেনারেল ঠিক আছে, এবার এখান থেকে নিজে নিজে এই লেগটার উপরে গিয়ে ওঠো, নিজে নিজে ওঠো।
Okay, in fact, examiner did not show any weakness, any sensory loss, no higher form or any high blood pressure abnormality, and the reflexes are all normal. So this is the video. Any thoughts as to what it could be the problem for this patient? A disability due to what?
Lance.
Okay, so what you observe is what? He has got myoclonus. In action precipitated myoclonus, industrial myoclonus. Everything normal. See the second part of the video. Typical industrial myoclonus.
ডান হাতে সেরকম নেই, ডান হাত দিয়ে করো এবার।
Diagnosis now. Same industrial myoclonus due to hypoxic encephalopathy, that is Lance-Adams syndrome. This is the MRI of the patient, showed cerebellar atrophy and pondent atrophy a little bit. Rest of the scene is brain parenchyma are all normal. Again, you can make out the cerebellar atrophy in this patient. EEG was normal. So it's Lance-Adams syndrome. So any questions? It's a short case, straightforward case, nothing great, but only thing is some might not have seen this problem. It's a very common problem following. They may improve, everything will be normal, but left with only both positive as well as negative myoclonus. Any questions?
What did he respond to?
When phenytoin was tapered to 100 milligram OD dose with additional clonazepam 1 milligram, and I was asked to follow up after 1 week. On follow-up, a video taken after 1 week of Levera and clonazepam. All the industrial myoclonus has disappeared.
ডান হাত দিয়ে করো, অনেক কমে গেছে, জাস্ট ফেনিটয়েনটা কমিয়েছি। আমরা এতজন আছি
Initially used to get myoclonus standing on toes. On bending down, he used to have myoclonus. It's not there.
আবার করো, ঠিক আছে। এবার দেখো আমি ফিরে এসো, দিব্য হাঁটছো তো, রোগ ঠিক হয়ে গেল।
Okay. So any questions before I go to the next case?
Sir, what is your experience with piracetam or notropil in such cases?
I don't know, frankly speaking, I don't have much experience. I have tried initially, But nowadays, with the availability of levetiracetam and clonazepam things and sonizumide, so I hardly use paracetam.
Thank you.
Thank you. Any other questions? Shall I go to the next case? Okay. This is a story of a 44-year-old man. This case was given by Dr. Anis, who works with me in Pavangal Medicity Hospital. He came with history of pain over the left shoulder for the last 4 months. This pain did not increase with coughing or sneezing. There was pain on movement of the left shoulder joint was there. No sensory complaint. It's also a short case. So this is the complaint, pain in the left shoulder. That's his complaint. No history of any weakness. This is on examination. This area is pointing to where the pain was. Elevated shoulder normal. Deltoid normal. Biceps normal. Triceps normal. Wrist section is also normal. Finger abductor, small muscles of the hand were normal. Hand grip was normal. When examined his external rotatus, it was weak on the left side. He could not, the external rotatus is weak on the left side. On the right side, it is normal. The inner rotatus were quite good. Reflexes, biceps, supinator, triceps, they're all well inserted bilaterally with no difference. Then the examination also in the normal limits. There is no sensory loss anywhere in this patient. So examine the back for any serratus and DA weakness, and for the delta and the trapezius weakness. There's not there in this patient. So what is the diagnosis of this patient?
Brachial plexopathy.
Okay, good. Brachial plexopathy presenting with intraspinatus weakness. That is a very good thought. Many times it can present with isolated nerve involvement. So yes, weakness related intraspinatus with pain over the left shoulder cause brachial neuritis. Okay. What other examination would like to do in this section? Anything else you want? Clinical examination.
Initial abduction.
Okay, very good. Examine supraspinatus. This is what you meant, no? Correct. So that is initial abduction. What is perfectly right. It was done. The supraspinatus was normal. See, it's got a good power. And keeping it again resistance. See, it's good power on the left side. I could not overcome his supraspinatus power. So where is the site of lesion now? Is it a brachial neuritis or something else?
Branch to infraspinatus.
Okay, branch to infraspinatus. So likely etiology, what could be considered?
Well, he's a volleyball player.
No, he's not a volleyball player.
Idiopathic brachial plexitis with
Yeah, that's a good thought, very good thought. So the dictum is whenever you get one nerve involved, single nerve, be it ulnar or a median or crown peroneal, whatever it is, think of the first possibility and think of a pressure palsy or some local pathology, that has to be kept in mind. Of course, you have to keep the possibility of a brachial neuritis is very highly likely, but he has no other finding, no sensory loss, nothing on the hand, only pain. Okay, but what else you like to do in this patient? So I isolate infraspinatus weakness. So is there any site where you can have isolated infraspinatus weakness?
Notch illness, suprascapular notch.
Right. Not the supraspinatus notch. You get both where the suprascapular nerve goes underneath the ligament there. That will produce weakness supraspinatus and infraspinatus. But when the nerve turn around in the spinoglenoid notch, where it is compressed, you can get isolated infraspinatus weakness. So you want MRI of the shoulder? The site of lesion is the spinoglenoid. Let us see. This is the anatomy of this thing. This is suprascapular, which you can see there. That goes under. There is a ligament. The superior tonsil scapular ligament that is overlying the suprascapular notch here. Compression is occurring. Compression can occur at that level. In which case you get weakness supraspinatus and infraspinatus. But if the least compression is occurring in the spinal notch, only the muscle nerve supplying the infraspinatus get compressed. Okay, so the compression is not in the upper part, but after the supply to the supraspinatus muscle. So this is again another depiction. This is suprascapular again one. This is a spinoglenoid notch, which of this side of the infraspinatus muscle, where this is supraspinatus muscle situated. So this is the two compression again. This is the first one, supraspinatus. I mean the suprascapular notch, where you get compression of involvement of both muscles. If compression is occurring below that in the spinoglenoid ligament, you get infraspinatus muscle. One of the common conditions is a ganglion cyst occurring in that area, which can absolutely compress the and the part of the suprascapular nerve which supplies the infraspinatus muscle. So what do you want? MRI of the shoulder. Now let us see the MRI of the shoulder. This is a sagittal cut. This is a humerus. I can show the muscles later on. This is the infraspinator, the supraspinator. This is a cyst which you can see, the ganglion cyst. This is a subscapular muscle. I'll show the static picture later on. This is another view. This is spinal scap. This is cyst they are occupying. This is infraspinatus muscle in the back. Upper part of the supraspinatus. Anteriorly is a subscapular muscle. So this is the spinal scapula. That is supraspinatus muscle. Below the spine is the infraspinatus muscle. And anterior to that subscapularis muscle. This is from the sagittal cut video when you look at that. Now this is the location of the ganglion cyst in this picture, patient. Actually, the cyst is encroaching, going a little bit above also, along the spinoglenoid notch underneath the supraspinatus muscle as well. But it does not affect the supraspinatus nerve. I mean, part of the nerve supplying the supraspinatus muscle. This is again the ganglion cyst. This is another picture view showing that this is a location of the cyst. This is supraspinatus muscle, infraspinatus, and this is the location of the ganglion cyst. It is going little bit from the below. It is going across the notch to the suprascapular, the suprascapular, the notch where the supraspinatus muscle is situated. So it's a diagnosis ganglion cyst, the spinoglenoid notch. In fact, when I saw the picture, I also initially thought it's only brachial neuritis. But when the supraspinatus was fired, then the TD becomes different. The point is that very often we do not look for supraspinatus muscle. When you find infraspinatus weakness, we take it for granted that supraspinatus also is weak. Is it not correct? You hardly ever look for supraspinatus. But this case teaches you that you should check both the muscles sometimes.
Sir, he had pain or
yeah, he had pain in the shoulder.
Complaint what he was having.
He has pain in the left shoulder on elevation of the shoulder. There's probably the
Okay.
pressure of the ganglion cyst. Okay. Any questions?
So other than the pain, did the patient have any disability?
No, in fact, he had only pain. He never came with a disability. He never complained in weakness also. These are detected by Dr. Anis on examination.
So any treatment required at this stage?
Yeah, he need surgery. Because the ganglion, it's a simple thing. The ganglion cyst has to be removed and he'll be all right. Or it's going to progress again. Pain will persist, not only that the weakness also going to progress. It is compressing the nerve anyway.
Okay, sir.
Okay. Shall I go to the next case? This is a case, it's a long case. In fact, 2-3 years back, I presented it. I'm presenting it again because the patient had a follow-up is available. Some of you might have heard this, many of them may not have seen this case anyway. So this patient now is an age 15-year-old female. In fact, I had seen her at the age of her 15, when she was 15 years of age. Much longer when I was when after my DMI, when worked in Kottayam Medical, that is the time when I saw the patient. This patient was seen by me in 1985 when she was 16 years of age. Presently, she is 51. At that time, she presented with history of weakness of left lobe. She developed one episode of generalized tonic-clonic seizure 1 week after the onset of the weakness of the left lobe. Next day, patient developed weakness of the right lower limb associated with retention of urine. So she seemed something like a paraparesis plus one episode of seizure. She was admitted in the medical college and investigated. Remember, at that time, there's no CT, MRI is available. Not even a tilt table for doing a myelogram. The discharge cut revealed that she had features of myelopathy. At that time, she was thought to have Curie ADM, and naturally because she's got a seizure and a myelopathy. CSF was done, which showed protein 45 milligram per deciliter, sugar 72 milligram, and no cells. This is the disease summary at that time, 85, demyelinating disease, spinal cord and brain. Patient was given steroids and weakness improved almost to normalcy. Remember, no imaging was done, only CSF was done that time. Patient was seen again in 88, that is 3 years later. Then she had worsening of his paraplegia. At that time, she also detected diabetes also, probably seroid might have worsened the diabetes. So at that time, repeat CSF was done. We showed cells of 112 per cubic millimeter, predominantly lymphocytes. However, protein was normal, sugar was normal. This is the discharge summary at that time. She was seen in a hospital in Trivandrum. These are all, this time I have not seen the patient. This is the record, this is history I got from the records. Then subsequently I saw her in Trivandrum after some period of time. Then I did a CT myelography because MRI was not available to find out any compression because she had recurrent paraplegia again, worsening paraplegia again. So CT myelography did not show any evidence of any cord compression. Next hospital admission was 2012. That means from 1988 till 2012, she is not come for follow-up. Anyways, I was also not in contact at that time. In between, she had gone for various other treatments. She did not have any hospital records with her for those treatments. But she had an MRI brain with her, which was taken in 2012. Why the MRI was taken, we do not. MRI brain was taken, we do not. Because she came she was seen subsequently in another hospital in 2012 after a period of about, say, 14 years. And that is she had an MRI of the brain. So this is the MRI of the brain done in 2012. I'll show the picture there. This is a flyer sequence. There is some hyperintensity in the white matter, probably in the basal ganglia also. Subcortical white matter hyperintensity bilaterally. This is the T2 weighted sequence. The basal ganglia hyperintensity is not very striking, maybe with poor quality film in the flyer. But there is some hyperintensity in the subcortical white matter, the occipital lobe, bilaterally, near the ventricle. Again, you can see adjoint the ventricle, some white matter hyperintensity is there. The subcortical, the corona radiate also some hyperintensity. You can make it out in the subcortical white matter. This is a contrast study is done. There is no contrast enhancement of the lesion. So this is the report. Bilateral asymmetrical confluent periventricular white matter hyperintensities involving corona radiata, centrum semiovale, sparing the cortex suggestive of demyelination. So MRI spinal cord was also done at that time, that is in 2012. There is no evidence of cord atrophy, no abnormal signal alteration in the spinal cord. Then patient was seen again in another medical college, that is in Kollam Medical College, in February 2020. At this time, she was admitted with severe diarrhea and treated by gastroenterologist, and the diarrhea improved. Patient came back again with worsening of the weakness of both lower limbs in September 2020. The diarrhea was February 2020. In September 2020, the weakness worsened again. At that time, examination revealed severe spasticity of both lower limbs. These are all, I have not seen, these are from the hospital records. MRI brain and spine was repeated in 2020. This is a repeat MRI. This is a T2 weighted sequence. I'll go slowly one by one. There is still subcortical white matter hyperintensity, but seems to be a little less than the previous. And is it probably because of the poor quality of the recent one? We do not know, but seems to be a little less. But still, the white matter hyperintensity is there. There was no cord signal changes at this time. At this time also. So this is multiple bilateral asymmetrical confluent to white matter hyperintensities involving the periventricular white matter, and is seen extending radially from the body of the ventricle toward the corona radiata, centrum semiovale, and sparing of the callosocaptal interface, such as demyelination. So this is a report in 2022. Patient was given steroid with minimal improvement at this time because the paraplegia is worsened. Now, when I joined this particular medical column in November 2020, then I saw the patient again because he came to me because I had seen her first in Kottayam Medical College in 20 years back. So I saw her after a gap of 20 years. So this time she came with the worsening of difficulty in walking for the last 2 months. At that time only I saw the previous records where she has gone to various hospitals. So examination at this time showed she was wheelchair bound. Hymenal functions were normal. And she was findings examination was confined to both the lower limbs. She had spastic paraplegia with bladder affection. And so I ordered these investigations. So MRI dorsal spine was taken. This is the T1 weighted sequence. T2, again cord normal. Dorsal cord also is normal. Then T2 axial. In a contrast also, it is also normal. No obvious cord pathology was seen, even though she got worsening of the parameter. Again, it's worsening every time after period of improvement. So I did various other investigations at that time to find out cause of the recurrent demyelination. So ESR was 22. PET count, everything was within normal limits. CRP, rheumatoid arthritis, etc. were all normal. Antiphospholipid antibody was done, is also normal. CSF was repeated. Again, total results less than 5. CSF VDR was non-reactive. CSF sent for polygonal bands, no band seen. NMO and MOG was sent again negative. And EEG was normal. So this is the story. Again, it's a recurrent paraplegia in between episode of one episode of diarrhea and vomiting. So for a better diagnosis, for want of a better diagnosis, continued on steroid and azathioprine. On 3/9/21, she was admitted in the same medical college with the loose stools. Patient was given antibiotics and other supporting measures. Diarrhea improved. In 26/9/21, that is September 21, the same month, 3 weeks later, she was admitted again with constipation and abdominal pain. During the hospital stay, she was observed to have episodes of apprehension, sweating, and irritability, for which psychiatric consultation was sought and treated by psychiatrists. Patient improved over a period of psychiatric symptoms improved over a period of 10 days. In October 21, this happened in September. Now, in October 21, 1 month later, she had worsening of the weakness of both the lower limbs. An examination revealed spastic paraplegia with the loss of posterior column sensory loss in the lower limbs. MRI brain and spinal cord was again repeated third time. This is MRI brain in October 2021. This is a T1 weighted sequence. SWI, T2 flare. That shows hyperintensity in the periventricular region extending onto the occipital white matter. They can make it the white matter hyperintensity there. And the periventricular area also showing the white matter hyperintensities. Again, you can find the coronary radiata white matter hyperintensities. This is the T2. There is no diffusion restriction anywhere in the lesion. That's only a T2 shine through we saw in the diffusion. SW was not remarkable, not showing blooming anywhere. Further course, for the next 6 months, she was noticed to have excessive anxiety, palpitation, and sweating, lasting for half to 1 hour, which was diagnosed to have panic attacks. Diagnosed to be panic attacks. She was put on propranolol and clonazepam, and her symptoms improved over a period of 2 months. During this period, patients also noticed to be excessively jocular and found to have difficulty in speaking. So she started developing high mental function problem. Examination revealed defective comprehension and abnormal posturing of her both upper limbs. This was followed 2 months later by weakness of both upper limbs. When the weakness developed, the abnormal posturing disappeared. What is abnormal posturing? Maybe some dystonia or some spasticity. Abnormal posturing, we do not know. Then during the second half of 2021, she had multiple admissions in the hospital. She had behavioral issues in the form of agitation, excessive anger, anxiety symptoms, and severe sweating and palpitation. So she had behavioral as well as autonomic disturbances. At times she was excessively jovial. Later on, her word output decreased with excessive laughter in between. She stopped eating with her hand because the weakness progressed. So I could not eat with her hand. When I saw initially only lower limb weakness. So she was seen by me again in November 2021. At this time, she was totally unable to walk, unable to do any activities with the upper limbs, and severely decreased word output. So what I thought is I am dealing with something very strange disease. I did not know what it was. So I called her for a detailed evaluation in the present hospital where I am working from Kollam. I asked her to come over to Trivandrum. This is the examination. This is the first time I take the video of the patient. Before that, all the time she got paraplegia, nothing more to take, need not think anything more beyond paraplegia. When she did hymen function abnormality, that's the time, then they got admitted again. So look at the patient now. Whenever I say something, she repeats the same thing.
എവിടെ വീട് എവിടെ വീട് എവിടെ വീടെന്ന് പറയാം
It means how she go on repeating the same word.
വല്ലതും കഴിച്ചോ രാവിലെ
I asked her, what did he eat?
എന്താ കഴിച്ചത്
He goes on repeating the same word again and
എന്താ
again.
എന്താ മോളുടെ പേര്
He's telling the same word again and again.
എന്റെ കയ്യിലുള്ളത് എന്താ
Asked her what it is.
കയ്യിലുള്ളത് എന്താ
She's not able to say. Probably she's goes into something like a translation.
എന്തായിരുന്നു സാധനത്തിന്റെ പേര് പേര് പറ കൈ കെട്ടിയിരിക്കുന്ന എന്തുവാ ഇത്
Sometimes she says the name correctly.
ഇതാരാ ഇതാരാന്ന് പറഞ്ഞേ
Sometimes she becomes unresponsive in between transiently.
മോളാണോ
And she starts responding. Ask her daughter's name.
ഇടത്തെ കൈ പൊക്കിക്കേ
Ask her lift up her left upper limb. She was
വലത്തെ കൈ ഒന്ന് പൊക്കി
then started examining. She got rigidity of both upper limb. Then hand gives her weak bilaterally. But she had about 2 to 3 power in the upper limbs.
പിടിക്കല്ലേ ഒന്ന് മുറുക്കി പിടിച്ചേ അതിന് കൈ വിട്ടേ വിടെ വിടെ വിട്ടേ വിട്ടേ കൈ വിട് കൈ ഒന്ന് പൊക്കിക്കേ ഇതും പൊക്കി
Weakness is more in the right upper limb
കൈ
compared to the left.
പൊക്കിക്കേ മുകളിലോട്ട് പൊങ്ങട്ടെ രണ്ട് കൈ പൊക്കിക്കേ പൊക്കിക്കൊണ്ട് വാ പൊക്കിക്കൊണ്ട് വന്നേ
Lower limb is in a grade 1 to 0 power. There is both spasticity and both lower limb. She has
കാല് മടക്കി
spasticity.
ജാസ്മിനെ
She could not move the lower limb at all. Georgia was normal. Both upper and lower limb reflexes were brisk except angle jerk. She is found to be diabetic also. It was brisk. And angles were absent. Plantar was both upgoing. Since the examination was not possible, see, this is on the first day. Second day after admission to the hospital, she was suddenly excessively jocular.
എവിടെ എന്നെ മനസ്സിലായോ ഞാൻ ആരാ ഞാൻ ആരാന്ന് പറയൂ ഞാൻ ആരാ പറയട്ടെ ഞാൻ ആരാന്ന് പറ എന്തെങ്കിലും കഴിച്ചത് എന്താ ആഹാരം കഴിച്ചേ എന്താണ്
She's again having a echolalia.
അപ്പമാണോ അപ്പം മുട്ടക്കറി അല്ല പിന്നെ ആരാ പിന്നെ ആരാ അങ്ങോട്ട് നോക്കി ക്യുക്കായിട്ട് നോക്കി അവിടെ പെട്ടെന്ന് നോക്ക് അവിടെ നോക്കിക്കേ
The
നീ
cranial
ഇവിടെ
exam is
കയ്യാ നോക്ക്
grossly normal,
മുകളിൽ നോക്ക്
except for poor attention.
നാക്ക് അങ്ങോട്ട്
So an examination, patient is conscious with excessive jocularity. At times she goes into a trance-like state with a mute state. She had profound echolalia and palilalia, which hindered a proper high level examination. I would repeat it many times to get an answer. She could recognize her daughter, but could not name objects occasionally. Cranials were normal. Motor system, rigidity of both upper limbs. Lower limbs were severely spastic. There was weakness of both upper limbs, more on the right side, but 3 to 3 plus power, grade 0 power of lower limbs. DTR brisk in both upper and lower limbs, except for the angle checks. Plantar upgoing. Grass reflexes present. Now, this is the story of the patient. She got, in summary, she has got recurrent paraplegia, initially responding to steroid, again worsening again. Then started developing diarrhea, gastrointestinal symptoms, and constipation, alternating diarrhea and constipation. Then she developed something like a behavioral problem, excessive jocularity, lack of concern about her illness. Then autonomic symptoms like palpitation, sweating, etc. Before that, one question I'll ask you. Before that, what is a speech abnormality? Probably, since she's speaking in Malayalam, you may not be able to understand. But she has got tremendous difficulty in bringing out the speech. And she is repeating whatever I say. What is her name? His name. I tell that. Again, not only that, the last word she continued to repeat. Not only that, she repeats whatever the examiner is telling. And she tells one sentence, the last word she goes on repeating. That is palilalia, the other is echolalia.
Verbal perseveration.
Yeah, okay. Perseveration is little different from palilalia and echolalia. Echolalia is patient echoes what you are telling. That is not perseverance. Whatever you say, patient echoes. Perseveration is patient continued to perseverate what the patient was telling. Or there may be for a second stimulus, it repeats the first one. That is perseveration. When somebody is telling the last word repeatedly, suppose you ask him, what is your name? My name is Madhu, like that is that's more like a palilalia. Okay, that is palilalia. Where do you find echolalia and palilalia?
Frontal lobe dysfunction.
Yeah, frontal lobe can produce. And one speech abnormality associated is also got difficulty in word finding, difficulty and all. Which aphasia is likely to cause more of echolalia and palilalia.
Transcortical aphasia.
Correct, exactly correct. Transcortical motor aphasia. In fact, there are two variants of transcortical motor aphasia. The first often manifests initially as mutism, which resolves to poorly initiated and non-fluent output speech, like something like a Broca's aphasia, characterized more by an articulatory disturbance than by language disturbances. Output is normal during repetition. Repetition, as all transcortical aphasia, repetition is normal. Combination naming is also well preserved since this is motor part. There is some debate as to whether this form of transcortical motor aphasia is truly an aphasia or not, because main problem was motor output. So it occurs with infarct in the territory of the left antecerebral artery, particularly with involvement of supplementary motor area. If you look at the causes of transcortical motor aphasia, they mention this also, supplementary motor area due to antecerebral artery infarct. Isolation of supplementary motor area results in impaired motor programming before to overt execution language output. That is why they have got something mimicking an aphasic syndrome. In fact, the rail one or the second variety is the dynamic variant of transcortical motor aphasia. The second variant of transcortical motor aphasia, called dynamic variant, is characterized by very sparse language production as in our patient, which gives the impression of a reduced intention or motivation to speak. The speech produced is well articulated, but with poor syntax and narrative. Although patient this form of transcortical motor face a difficulty in initiating the recital of routine series, like naming the months of the year or nursery rhymes on request, they easily complete the series after the examination provided the first few elements. If you give the first two elements, say Monday, Tuesday, then she'll continue with that. But she found difficulty in repeating the route in the routine way. As a rule, these patients answer simple questions relatively easily, frequently beginning their reply with echolalia repetition of the question. The dynamic variant of transcortical motor occurs with the damage to the left frontal cortex, anterior or superior to the Broca's area, involving the middle and superior frontal area. Echolalia is a prominent component of the mixed transcortical aphasia, and like intact repetition, can be thought of reflecting the preservation of the automatic aspect of speech, of language, devoid of any ideational content. So this is from the literature only. So the type of aphasia which produces profound echolalia and paglialia is this one, transcortical motor aphasia. These people have tremendous difficulty in getting the word out, so they go on doing some gestures like this. Like that, they do the gestures to bring out the word. Anyway, that is the sideline, what the abnormality was. So in our patient, which are the sites affected to cause disability? More than one site, obviously. It's got initially got paraplegia without any element, so it's got a cord involvement is there, even though Mari did not shows it or not. You cannot explain the paraplegia due to cortical lesion, because there's no cortical symptoms at that time. Recently, only for the 2 years only, she is developing the high functions problem and psychiatric symptoms. So she has got cord involvement, and she has got bilateral pyramidal signs affecting the upper limb, pyramidal weakness. She has got prefrontal cortex involved because of the excessive jocularity, and probably dominant frontal cortex for his transcortical motor aphasia. So these are the probably hypothalamus also booked because of the autonomic involvement. So bilateral prefrontal lobe, there is mainly orbitofrontal, transcortical motor aphasia, bilateral pyramidal weakness of upper limbs and lower limb, predominantly in the lower limb, 0 for the lower limb. So what investigation you want? Already, you know, the previous MRI had been done, it's showing multiple bilateral cortical white matter. The cortical white matter. There was no cord changes in the scene, the previous MRI.
Or is there any hyperpigmentation?
Hyperpigmentation is not there. She's generally black in the color, but all throughout. It will be difficult to make out hyperpigmentation in that patient.
Okay, sir.
So I worked up the patient in the PRS hospital. We were working. I did a repeat MRI again. So this is the T2 weighted image. See, now the picture has become much more very clear now, in the sense that the lesion has become very well seen. I will show the picture once again. Periventricular hyperintensity is seen throughout in the, not only in the coronary data, but also in the periventricular location. This is the coronal cut. Again, you can make out the hyperintensity in the subcortical vein, which has become more diffuse. This is the flare sequence.
There's a clear space between the ventricular margin and the
There is also some degree of cortical.
I think it's abnormal.
You can make a hyperdensity. Joining the ventricle, there is a spared area of cortex, white matter.
Clear zone between. I think there's a little effort in your place.
The T1, which not contribute to anything. That area was hypointense. The sagittal T1. This is a diffusion which is not contributing anything. There's no diffusion restriction. So impression, again, no evidence of intracranial hemorrhage, acute infarct, diffuse cerebral atrophy, diffuse confluent T2, hypertension with periventricular white matter. This is the small vessel scheme. This is a radiologist report. Now, what else you would like to do? MRI was done. Previously, the demyelinating workups are all negative.
Whole exam sequence.
Okay.
Any form of
Right.
leukodystrophy, sir?
Any form of?
Leukodystrophy, sir.
Yeah,
Chronic.
that's one. Yeah, that's a very good thought. No? This is symmetrical finding white matter hyperdensity. That should be the one of the topmost priority. But only thing is clinical picture is not fitting. She person with total paraplegia improved to normalcy. They again recurrent episodes of paraplegia, then developing hyperlipic abnormality like that. So what could be the possible condition? One leukodystrophy is, of course, if you disregard the waxing and waning picture of this, I mean, we would definitely consider leukodystrophy.
Metabolic.
Mitochondrial disorder.
Mitochondrialism, like melas and things like that. But that MRI is not like this. Anyway, EEG
Serum
was all.
cortisol is normal. Serum cortisol.
Serum cortisol, I do not know whether I have done that time and that not. It is not there. In fact, I don't think it was done. This EEG was done, it's just normal. So thinking mitochondrial cytopathy, CSF lactate was done. Lactate was 7.5, again normal range, not increased. HNA profile was repeated for small muscle disease. SSCP was also done. So these are the possibilities: secondary progressive multiple sclerosis, leukodystrophy, mitochondrial cytopathy. So these are the thoughts I had in my mind at that time. So anything like to add?
An HIV present.
What is about the paraneoplastic, very slow process for a
No,
pretty autoimmune and autoimmune?
No, that I did not consider at all because the duration was more than 20 to 22 years.
Autoimmunity?
No, 22 years duration. No? It's very, very uncommon.
She was getting some sort of a steroid and all this thing. Autoimmune can be,
Yeah.
and a history of diarrhea.
Yeah, that's there. But it's very uncommon, no? But having to remain like that for a long period of time. And even on steroid, I think she's again worsening again. And on newer symptoms are added on. She was not responding to immunosuppressants at all.
So this MRI picture will it fit with HIV?
HIV was very much likely with this patient, but again, the presentation is very odd. If you're in the last part of the picture, HIV could be a possibility. They can have a diffuse white matter hyperintensity is well known in HIV. But again, duration, initial presentation, paraplegia with recovery, all clinically is not fitting with HIV. MRI wise, it could. Because that is one atrophy with white matter hyperintensity is HIV. So what next?
PNS vasculitis.
Vasculitis was thought of, but it was there is everything like vasculitis workup was negative. Second time also it is negative. Again, the MRI picture is showing diffuse white matter. It's bilaterally symmetrical. So when you get diffuse bilaterally symmetrical, you should think of one leukodystrophy, second a neurometabolic disease. Maybe mitochondrial also, but more like a neurometabolic disease. Because that produces symmetrical white matter. Other is leukodystrophy. Clinical picture was not fitting with the leukodystrophy. So what metabolic neurometabolic disease can present like?
Wilson's can present like this, sir.
Wilson's.
Huh?
Wilson disease, the client should first involve the basal ganglia first and midbrain. But here is a white matter abnormalism without affecting the basal ganglia. So,
Metachromatic leukodystrophy.
yeah, leukodystrophy is one that's already considered. The second person is symmetrically white hyperintensity. Only thing is the course is slightly odd. She's from the age of 18, 16. I'm seeing her for the age of 50, 54. She's still there. Since there is progressive white matter changes in the form of symmetrical periventricular configurations, the possibility of neurometabolic, mitochondrial, and leukodystrophy was considered. This is why final impression thought. Hence, clinical exome sequencing was done. The interim period till the result came, patient deteriorated. Speech deteriorated and could only mumble and incomprehensible. This is the speech reversal. Mumbling, make some meaningless sounds. Subsequently, patient became totally mute and immobile.
Okay, this is good.
Not responding to anything.
ജാസ്മിനെ കാണണം, ജാസ്മിനെ കൊണ്ടുപോകണം. പോകാൻ മതി. ജാസ്മിനെ കൊടുക്കണമെന്ന് പുതിയ മരുന്ന്.
And the results came, mitochondrial panel, there's no mitochondrial, no pathogenic like pathogenic variants done. So diagnosis was there in the other clinical exome sequencing. Any thoughts? Anyone can make a guess? I did not think of that possibility. And this is what the patient had. That is methylene tetrahydrofolate reductase deficiency. That is methylene tetrahydrofolate reductase. It's an eminently treatable condition. Producing homocystinuria due to methylene deficiency, likely pathogenic. So this is MATHR mutation causing homocystinuria deficiency. So then I said the serum was sent for homocysteine. That's the first time after seeing the results sent for homocysteine. Homocysteine was very high, 79.8. Because this particular enzyme is required for the vitamin B12 metabolism. So patient was put on IV methylcobalamin, 1000 microgram per day, folic acid 15 milligram per day. This all I searched the literature to find out the treatment. I never seen the case before. Pyridoxine 40 milligram daily, revofloxacin 500 milligram. Revofloxacin 500 milligram daily. See the number of tablets she has to take. Along with betaine 9 gram daily. I was not knowing what is betaine is. So betaine, I searched the literature. Betaine is a modified amino acid consisting of glycine with 3 methyl groups that serves as a methyl donor in severe metabolic pathways and is used to treat genetic causes of homocystinuria. Glycine betaine is the amino acid betaine derived from glycine. So this is the tablet which I got through the net from the through the net. I could purchase that thing. Is betaine DMG. So she was given that also. So even after starting this treatment, see, she was put on nothing great, only vitamins and revofloxacin betaine. Even with 3 days of exposure to the medications, patient started showing signs of improvement. She started vocalizing, making sounds. Started became conscious at least. Follow up after 1 month. She said, answering question. Correctly to my questions. Asked her what all things she had in the morning. She started obeying my movements and all. Yet spasticity of the upper limbs is persisting. Lower limb paraplegia did not show any improvement. Upper limb power improved. The reflex remained brisk in both upper and lower limb. There's no change than before. Able to feel vibration, not in the lower limb. They can follow up after 3 months. Not 3 months. This is after about 1 year. Because there are 2-3 other videos which I purposefully did not show you because in the interest of time. So this is after 1 year of treatment, almost 1 year of treatment. I mean, we're all normal. Upper limb power has become normal. Tone has become normal. No incoordination. Lower limb, there was no improvement in the motor power. That remains static. The reflex in the upper limbs remain brisk. She was able to feel pain except for the distal aspect loss because of the diabetes. Other things have become normal. She's able to feel. Initially, she was not able to feel. She's able to feel the vibration also in the even in the lower limb. Decrease the dose, but otherwise present. Upper limb normal, lower limb also normal. She said correctly. Initially, she had sensory loss, the lower that improved, but motor weakness did not improve. So this is the condition. This is the prescription for this patient. And this we could publish it in the this thing. But subsequently, when you search the literature, lot of case reports of this particular condition presenting us in various forms. As a cause of treatable adult onset leukoencephalopathy and myelopathy, adult reductive deficiency, again another one. Adult onset paraplegia, one. Psychosis, paraplegia, and coma revealing. Again, just like our patient, paraplegia and psychosis. Reversible spastic paraplegia with novel mutation. Isolated treatment, this neuropsychiatric symptoms. So all this can present with various ways, neuropsychiatric symptoms, paraplegia, recurrent paraplegia. So that's the story of this patient. So whenever you got a doubt, if you find this kind of a white matter abnormality, it's cortical with cortical atrophy, think of this treatable condition before, I mean, of course, consider leukodystrophy. But this is also one of the conditions you have to keep in because this is treatable condition. If you could have made I could have made the diagnosis earlier, the paraplegia could have been averted. Because it was a burned out case of paraplegia, because it started from the age of 16. She went to many places after that. I saw her only 20 years later. Even if I had seen earlier, I wouldn't have made a diagnosis. At that time, genetic test was not available.
Sir, how is it, like, what sort of, is it sporadic mutation or?
No, about the details of which I don't know. This is the only thing, genetic disease in the methylcobalamin metabolism due to the deficiency of this particular enzyme.
Sir,
Yeah,
I-
please.
whenever I see a homocysteine report more than 50,
Hmm.
I routinely send for MTHFR deficiency, and I must have at least 100 patients who have shown either homozygous or heterozygous deficiency.
Okay, fantastic.
Invariably, if the homocysteine is more than 50, there is an MTHFR deficiency. And homozygous, if there is homozygous, I always give this trimethyl glycine, which is available as Trimeg sachets by Novo Medicaments. And
Yeah,
Trimeg, like the one that you said, betaine. So I routinely
Betaine.
give along with the folic acid, B12, and the routine stuff that we give for homocysteine, and they usually do well. The only learning point is that besides strokes, any other unexplained neurological symptoms, I think one should send homocysteine as a screening test. And if homocysteine is anywhere more than 35, then always send for MTHFR deficiency genetic test, which is very rewarding.
Very, very rewarding. As you said perfectly, you said correctly, perfectly said, well said. That this is one lesson which you have to learn. That whenever they see, as you said, they can present like a stroke, but the first time learning is can present with recurrent paraplegia. That I never thought this homocyst could have present like that. But you remember that this is also one presentation of homocysteine, English homocysteine level.
So the paraplegia localization is in the spinal cord or is due to the brain, sir?
No, spinal cord, not auto spinal cord.
It would be similar to subacute combined degeneration kind of.
Exactly. If you look at the presentation also, she got told, only thing is that it was not the usual type of SCD. Zero power, no, level in the cord, below the zero upper limb normal. That's not the usual pattern in SCD. And she had post-column involvement in the lower limb also subsequently. Initially, it was not there.
And
Unlike yeah, please.
Improvements that we saw could have been due to steroids plus IV B12 that she might have received during the
Exactly what he said is correct. Invariably, we admit there, we usually give injection to neurobion, or things like that. That is a routine cocktail which we give whenever there's a patient. That is why she must have improved in between. We thought it has improvement was due to the steroid. Actually, it's not a red herring. The associated vitamins which we might have given might have produced improvement.
There was no involvement of the spinothalamic tract, sir.
No involvement in spinal therapy. No, she had dystonia that is due to the diabetics. She has got diabetes also. Whether that is not clear level of pain in the trunk, but only the posterior column is affected. Even in the end stage, she has got distal symmetrical pain loss. That's most likely due to, and angle jack was also decreased, more likely due to the diabetic pressure.
Diarrhea is due to diabetic autonomic neuropathy.
No. It's due to the disease process itself. It is described that these patients can have psychosis, they can have autonomic imbalance, everything is described with MTHR deficiency. This homocysteine is doing havoc in many parts of the brain.
Sir, I would just like to share one experience that I had a patient of venous sinus thrombosis, where it was secondary to hyperhomocysteinemia, and later on MTHFR deficiency was detected, and I put on various, the anti-homocysteine kind of medications. Then in between, she lost the file, and then she was coming for follow-up, and I forgot that it was MTHFR deficiency. So I stopped the vitamins. And she came with some non-specific symptoms where they brought the file and I did the MR venography to see whether she is again developed a venous sinus thrombosis
Okay.
because I stopped the homocysteine medicines. And the MRI was normal, but when I restarted the anti-homocysteine regimen, her non-specific symptoms all improved.
Correct, exactly. Because I searched the literature for writing the article, then I found a lot of literature on telling the autonomic imbalance, as you said, psychiatric symptoms, etc., with MTHR deficiency due to hyperhomocysteinemia.
So, sir, you treat them with betaine as well as methylcobalamin, or what is the maintenance treatment that you give for these patients?
Now that's the treatment. I'll show you. This is the treatment I given. See, high dose of vitamin folate, riboflavin, benadryl is vitamin B6, and betaine. These are the three things which I give. That is what is given in the literature. I just copied and then gave her.
No beetle.
Beetle is also there.
Sir, I usually give the regular B12, folic acid, pyridoxine along with betaine for 3 to 6 months. And by the time the homocysteine has come back to normal, then I take out the betaine and continue the regular folic acid, B12 and pyridoxine lifelong. But and keep checking periodically the homocysteine. If the homocysteine rises again more than 25, then I add betaine for a short period of time. But betaine, I think, in my experience, works to in the acute phase to improve the main symptoms. And for maintenance, once the homocysteine has gone down to normal levels, then just maintenance therapy with folic acid, B12, and pyridoxine. That works.
Betaine is not costly at all. The particular patient is continuing to take betaine also even now.
It is 25 milligrams a sachet and once a day, so not at all.
Yeah, very not costly at all.
So even if the patient is totally paraplegic, the code is normal. So is it some electrical disturbance or any other explanation for the patient being zero power and code being?
He's got a zero power both the lower limb and cord is normal. MRI is normal.
Yeah.
And,
so what is the explanation?
Sensory, there is a sensory level, bladder involvement. Presentation is like what? Acute onset.
There is a clinico-radical dissociation. So what is the explanation for that clinico-radical?
That depends upon the nature of the disease. For example, if it is a slowly progressive disease ending in totally weakness like that, or acute presentation, subacute presentation, that's the thing I would like to know. Because chronic progressive, you may not find anything in the cord at all. Degenerative disease and neurometabolic, you won't find anything in the cord. The acute lesion, subacute, well, most likely you like to see some abnormality in the cord. If the cord is entirely normal, again, clearly look for any dural AF fistula also. Someday for that, you have to, MRI may be normal in dural AF fistula. MRI spinal cord may be normal. The congestive myelopathy may not be there all the time. Unless you do special sequence like a space T2, you will miss the vascular channels also. There was one article came in Practical Neurology. They said that is paraplegia with normal MRI. One of the causes is dural AF fistula.
Almost causes wrong localizations.
Location, if it's correct, it is the thing you have to keep in mind.
Sir, in some cases of subacute component degeneration, where B12 is normal, should we look for this enzyme mutation?
No, B12 is not at all a criteria to diagnose subacute. So B12 may be entirely normal in B12 deficiency because there is the problem is the one is the estimation method is wrong, likely to be 40. Always ask for homocysteine level. Because 2-3 times I have shown vitamin D B12 deficiency patient classical findings of SCD with normal B12 level. So don't believe on the vitamin B12 level at all. But believe only on homocysteine level. Or the ideal thing is methyl malonic acid, which is not available. You cannot do it here. I don't know, some other lab may be doing it now. So it's not routinely done, but homocysteine routinely done. So always rely on
Should we
your
look for
mom.
this enzyme mutation should be looked for?
Yeah, and so that's the thing. That's a lesson, no? So the usual causes of nutritional deficiency and all, I will say antiparental antibody, gastrin antibody. That is the thing. We stop at that level. If you find that the vitamin B12 and this thing is all negative and homocysteine is elevated, and the percentage patient is not responding, then you are definitely to rule for MTH additions.
Sir, a practical approach in my 30 years of experience, with homocysteine at least more than 20 years of experiences, we do homocysteine, and if the homocysteine is raised but not too much raised, 20, 30, up to 40, usually MTHFR doesn't come positive. I send them when the patient is affording, I send the genetic test, but I don't find it positive. But if the homocysteine is more than 50, more than 65 as the report, invariably it comes, MTHFR comes positive. Either heterozygous or homozygous, one gene or the other. There are two genes that they test. Two mutations that they test. If it is between 40 and 50, sometimes you get positive, sometimes you don't. So that is the general criteria I use, that if the patient is not affording and the homocysteine is not higher than 40, 45, then I don't send MTHFR. But if it is more than 45, I tell them collect some money, sooner or later we'll do this test. And MTHFR I always do if it is more than 50.
Correct. That's a good point. With very high level, think of this particular condition.
What is the approximate cost for a genetic test?
Well, that is, cost has now come down. For the whole exome sequencing, can be done at 12,000. Clinical exome 9,000 and 9,500.
They even do MTHFR single test. MTHFR,
yeah, that of course, that can be much less costly.
Yeah.
Sir, in the MRI brain, there was some change, like there was some normal area, normal white matter between
Correct.
So is it an indication for this particular condition?
No, I do not know. See, I have not seen many cases of MTH elevation. See the MRI findings also. This is one peculiar finding which I noticed, that's I pointed out. It is not like the one which you see in classical leukodystrophy or in demyelinating lesions. It's a sparing, longitudinal sparing area in between the ventricular margin and the white matter hyperdensity. That also tell you this disease is something peculiar, neurometabolic disease or a leukodystrophy-like disease, which likely to selectively affect certain structures in the brain. So that is the one finding which I would mention here. Such kind of a selective involvement symmetrically occurring, think of neurometabolic, toxic, or degenerative like leukodystrophy conditions.
And T1 also was not showing any changes, even though T2 showed plenty of changes.
Correct. T1 is mild hypointensity, very mild, not very significant hypointensity, as you see in the demyelinating disease. Chronic demyelination, correct.
Sir, I have one doubt, sir.
Yeah.
Sir, you told paraplegia with normal MRI, spine.
Yeah.
Spinal dural AV twisted. So even we won't get flowoids also.
No, flowoids will be there, but the problem is that which can be easily missed. And
okay.
Okay.
Parenchyma,
Now the thing,
spinal parenchyma will be normal. That's what you're saying.
Yeah, exactly.
Oh,
That's
okay,
what
okay.
it is.
Okay.
And even with normal flowoid, even without seeing a prominent flowoid, this is possible.
Oh,
you have
okay.
to roll spinal dually hyperstrophy.
Oh.
But because I'll remember a case when the approach meet conducted last by Sudhir Kothari. This particular patient had recurrent paraplegia of subacute nature, normal MRI done 2-3 times. MRI report was normal, no flowoid seen. But because clinical suspicion was strong, angiogram was done normal, again repeated normal, third time picked up the dural fistula. By this different method they did the angiogram. So it's a dural fistula is a tricky condition which can be easily missed. If the clinical picture is very strongly suggestive, always do all necessary investigations, especially proper angiogram.
And sir, one doubt, sir. They say if we give steroids, they will worsen.
Correct. Yeah,
So,
yes.
so
Yeah,
what,
correct.
why is this, sir?
No, I also was curious to know why it is worsening. I searched the literature also. Nobody is telling any correct explanation why steroid is worsening.
The fluid retention and the venous congestion should be the cause.
Right, but that is the explanation they're giving. But do you think it is very likely in such a patient?
Thanks.
So
Why
that
not?
means, sir, that means if the paraplegia comes, even if normal MRI, we give steroids, if the worse than spinal angio has
No,
to
it's
be.
not. It's not a rule at all. Sometimes may not worsen at all. The worsening need not be taken as a criteria for radiology test.
Okay. So non-compressive myelopathy, CSF normal, so spinal angio is a must. That is what's the thing, sir.
Yeah, if the clinical picture is suppose the progressive paraplegia of long duration, suddenly with somatic evidence of any hereditary spastic paraplegia, clubfoot and things like that, that of course is different. But a presentation like acute or subacute or worsening with exercise, fluctuating course, and the picture is sensitive of developing fistula or ischemic myelopathy, always you have to investigate.
Okay, sir. Okay.
That's it.
Okay, sir.
That depends upon the clinical presentation.
Okay, sir. Okay. Thank you, sir.
Okay, shall I stop?
Yes, sir.
Okay, so we'll meet
Thank
next
you,
time.
sir.
Yeah,
Thank you,
good
sir.
night. Thank you, good
Thank you,
night.
sir. Good night.
Thank you, sir.
sir.
Thank you, sir. Good night.
Excellent
Thanks.
case. Thank you.
Thank you.
Thank you, sir.
Thank you.